Good afternoon and good morning to you if you are on the West Coast. My name is Dr. Jose Leon. I am the Clinical Quality Manager for the National Center for Health and Public Housing, a project of North American Management. I want to welcome and thank you all for attending today's webinar, Preparing Hospitals and Clinics for the Psychological Consequences of a Terrorist Incident or Other Public Health Emergencies. This webinar is being recorded and the resources, slides, and other materials will be emailed to you after the webinar has finished. At the end of the webinar, there will be a question and answer session, and I would like to kindly ask all of the attendees to complete the post survey after the webinar. Also, I would like to thank HRSA for allowing us to make this webinar possible through our publication grant. I'd like to get started and introduce our speaker for today's webinar. Sandra Shields is our Disaster Program Manager for the Los Angeles County Department of Health Services Emergency Medical Services Agency. Sandra has worked for LA County since 2001 and held a previous senior staff position in the County Office of Emergency Management. In her current position, Sandra is responsible for the Disaster Mental Health and Volunteer Program deliverables for the Hospital Preparedness Program grant. Sandra was formerly the Associate Director of Planning and Preparedness and Supervisor of Disaster Mental Health and Health Services for the American Red Cross of Greater Los Angeles. In her previous position, Sandra supervised a volunteer team of 200 licensed mental health and nursing professionals. Sandra is currently the Disaster Mental Health Co-Lead for the state of California with the American Red Cross. Sandra is a government representative to the California Disaster Mental Health Coalition and member of the Crisis Response Education and Resource Committee for the California Association of Marriage and Family Therapy. Over the past 23 years, Sandra has participated in 22 major disaster operations. Sandra has a BA in psychology from Pepperdine and an MA in clinical art therapy, marriage, and family counseling from Loyola Marymount University. She's a licensed marriage and family therapist, licensed psychological clinical counselor, board-certified art therapist, and certified trauma specialist through the Association of Traumatic Stress Specialists. I am now turning this over to Sandra. Good morning, Sandra.
Good morning, Dr. Leon. Good morning, everyone, and thank you so much for inviting me to present this information to you today. I'm really hoping that something that I say is going to be helpful, some resources that I provide is really going to help your clinics to better integrate the disaster mental health consequences of a disaster. Also, I wanted to say about how honored I am to present to this group. I know that you are on the front lines of healthcare every day, and I appreciate all that you are doing for our communities. I want to start by showing you a screenshot of the LA County Department of Health Services Emergency Medical Services Agency website. And I want you to notice that two things. The top arrow is it shows me, a picture of me, so that you know what I look like. Even though I'm in California, I don't look like a Hollywood star, but there I am, so that you know who's speaking. And the second arrow, much more importantly, I want you to know that we have lots of information that we've posted on our EMS agency website about Ebola, including some things specifically for clinics. So if you had any questions about what Los Angeles County is doing regarding our Ebola response for hospitals and clinics, it's all there for you to look at. This second slide, again, another screenshot. So when you click on that Ebola virus disease information, you'll come to a community clinics area. There's a link for a community clinic association for Los Angeles County. And also, you may be interested in Ebola preparedness and response for outpatient healthcare providers that was developed by the LA County Department of Public Health, just so that, again, if you want to look at what it is that we are doing, All of that information is there. If you would go down farther in all of these resources, many of the links are to the CDC website. Some of them are to our Department of Public Health. You will see there's also some mental health links there that also may be helpful for you. So you can always Google LA County EMS Agency, or if not, there's the link to our website. And also I wanted to let you know that all of the materials that I'm presenting today are posted on the EMS Agency website. The PowerPoint is there, the instructor script is there. So you can think of this as your train the trainer session, and you can bring this material back to your clinic and train it just as well as I can. The only caveat there is just that if you don't add anything, if you add anything to these slides, make sure that it shows your own background so that there's a distinction between your materials and ours. And that, other than that, it was developed through the Hospital Preparedness Grant Program, your tax dollars, so in fact you own this course as well, and please feel free to download it and use it. There are some other things on our website that may be useful to your clinic. We have developed a mass fatality management guide for healthcare entities, including clinics. If you'd like to download and use that, you can edit it away as much as you want. It's really good and easy to use. There's also a Los Angeles County Family Information Center planning guide, so that if your hospital or your clinic need to open an area where you have grieving family members that need to wait in private, this is the plan for how you do that. Again, you can download it, use it, and edit it. The California Hospital Association also has a lot of behavioral mental health resources on their website that may be interesting to you. The other thing to know is that the state of California used a large statewide coalition group to develop a disaster mental and behavioral health framework for the state of California that you can also download. And it contains recommended actions for the coalitions for the disaster planning, cycle, mitigation, preparedness, response, recovery, concept of operations and training. So again, if you're looking for a little bit of more information on the whole topic of how you integrate disaster mental health with your regular disaster plan, those should be some good resources for you. The other thing that you should know is that this training that I developed with RAND, the Department of Public Health and Mental Health in LA County, is just part of what we've done under the Hospital Preparedness Grant. In addition to this sort of basic training on how you integrate mental health into your regular disaster plan, we went on to do some other things. We've adapted the SciStart, a rapid mental health triage tool, to hospitals and clinics in Los Angeles County. We've also developed a staff resiliency system called Anticipate, Plan, and Deter. And so that's a little bit more. The SciStart disaster mental health triage system is able to help us to determine who may need more follow-up following a disaster based on proximity to the event, not symptoms, and helps us to develop a little bit more nuanced approach so that those who are highly exposed to a disaster have a different set of mental health protocols from those that were not there or who are peripherally involved. We're trying to get away from that one-size-fits-all approach to disaster mental health, psychological first aid, just giving people a little debriefing. If they've been highly exposed to a disaster, is really not going to be the right strategy. You need to do something a little bit more. Ultimately, we use our SciStart information to map out where our psychological casualties are in Los Angeles County. What you saw previously was a paper-based version. We now use a web-based version. And ultimately, it allows us to view where the psychological casualties are by hospital and clinic and clinics, and it helps us to determine what we need to do in terms of our response. You should know that Los Angeles County is a very large county. We have 88 cities within our county, not just the city of Los Angeles. We have over 100 hospitals. About 83 of them participate in our hospital preparedness program, grant program. and we have 33 clinics representing 90 sites, so it's a lot to manage. So this is the beginning of the course that I'm going into now, and we're going to talk about the psychological consequences of a disaster. Those really are the emotional, behavioral, cognitive, and somatic reactions that your staff and your patients will have following a disaster. And while most hospitals and clinics do have a disaster plan, it's not as common for the psychological consequences of a disaster to also be addressed. So the purpose of this course really is to give you some protocols and templates and manuals and tools. So this course, when you look at it on our EMS agency website, you will see some additional tools that we're also going to talk about that are attached to it that you can download and use. So we're going to talk about recognizing the psychological triggers of distress. We're going to be aware of the types of psychological effects of a disaster, some tools and principles, and things that will help train your staff and your facility to be better able to respond to the psychological casualties or consequences of a disaster because you've considered them in your disaster plan ahead of time. So this is the study team that developed this training, and you'll see that it was a collaborative effort between our county departments and the Department of also RAND, who was our contractor. The other thing that you should know is that Los Angeles County has been receiving hospital preparedness grant funds directly for about 12 years. Our state of California also receives funds, but the reason that we receive funds directly is because of how large our county is, and also because we are considered to be a key terrorism target. So cities like New York, Los Angeles, Chicago, Washington, D.C. have direct HPP funding. And we've used that to develop many programs, including the programs that are specifically designed for preparing hospitals for the psychological consequences of a disaster. So if you look through our EMS agency website, you'll see a number of things that we've developed under our grant program. So this training actually has 3 modules. We're going to be talking about the first module this morning, but there is a second module also available that you can use, and there's a third module that our Department of Mental Health adapted for their use. But if you're from a mental health department and you're wanting something a little bit more extensive, please feel free to look at those materials and use them. When you're talking about preparing for the psychological consequences of a disaster, each facility is different. Some clinics, some hospitals have disaster mental health or have mental health staff on site. Some don't. So the strategy on how you address those psychological consequences of a disaster, both for your staff and for your patients, will vary depending on what kind of resources that you have. Nevertheless, if you don't have mental health on site, you still need to develop some strategies in your disaster plan on the mental health consequences of a disaster. So we're going to talk about the psychological consequences of large-scale emergencies. We're going to talk about the triggers of psychological effects. We're going to talk a little bit about planning and what you need to include in your disaster plan, and again, some of the other tools and resources that are available on our website. So let's talk a little bit about the psychological consequences of a disaster. One of the reasons that we wanted to work with the psychological impact of disasters is that we're really concerned in Los Angeles County about the surge to hospitals and clinics following a disaster. And I think you can see with the Ebola response also that there's really a very large mental health component to how people are reacting. And so you have to have some type of plan that allows for the surge of concerned people coming to your hospital and clinics. In Los Angeles County, we know that if there's a large-scale disaster, especially something where there's a concern about people becoming ill, people are going to surge to our hospitals. They're going to surge to our clinics as well. Many of our patients consider their clinic to be the hospital. So they're going to come to that clinic thinking it's the hospital, and then the surrounding community that may never have come to that facility might come as well because they are concerned that they were exposed to the disaster. So I want you to keep that mental health surge idea in mind as I go through these slides. When I first started to teach this class, when I talked about the surge of psychological casualties, really there wasn't a lot of agreement in the room that that's what actually happens. And then we had H1N1, and people started to run to the hospitals asking for Tamiflu and thinking they had been exposed to that disaster. And so the hospitals were highly impacted by a surge of psychological casualties in that disaster. And my presentations became a little bit more popular at that time. And certainly with Ebola, there's just a huge psychological component to it that we need to be prepared for. So let's look at some past disasters and see if we can get a little bit more about that idea of the psychological consequences of a disaster really outnumbering the people who are actually injured, and needing, again, to have a strategy for people who come to your facility, including your staff with psychological concern. So this is the sarin gas attack in Tokyo of March 20th, 1995. This occurred at rush hour on the trains in Tokyo. There was a terrorist group that came into the trains. They brought sarin with them. They punctured the containers for the sarin, and sarin started to waft out, and people became very sick. In all, 12 people died in that disaster. 1,000 individuals experienced some symptoms of exposure, yet more than 4,500 sought medical attention, some presenting with physical symptoms such as difficulty breathing, but no sign of exposure. So for every one person that may actually be injured, we should expect at least 4 times as many may come to your hospital or clinic with some concern that they were exposed. They're not going to neatly present at the mental health clinic. They're going to come to you, and you need to have a strategy for that. So in Tokyo, 88% of visits were for people who were not exposed. In Brazil, there was a cesium isotope incident. Some of you may remember there was a clinic that was closed. People got into the clinic. They took part of the medical equipment out that was green and glowing and passed it around. 125 people were exposed, but 125,000 sought screening. 5,000 had symptoms of exposure, but they were never there. So some of the people that you may come into your clinic were never at the disaster. They may have symptoms of exposure. They may be very concerned, and you have to have a strategy to address that after they've been medically cleared for that incident. Washington, D.C., we also had an anthrax attack. There were 22 cases, but 35,000 received prophylactic antibiotics. Many had not been exposed, but the antibiotics were prescribed maybe by well-meaning physicians wanting to allay patient anxiety. So rather than giving the pill, it might be better to have some strategies. This is the SARS epidemic and pandemic, and this is very, very similar, I think, in some ways to Ebola in terms of the ongoing concern about the illness, monitoring the exposure. This had to do with a conference that occurred in Hong Kong, and then people leaving the conference and going out in other parts of the world. And so some people went from Hong Kong to other provinces of China. There was 95 healthcare workers and 100 close contacts that were affected by SARS. One person went to Vietnam, resulting in 37 healthcare workers affected, 21 close contacts. 3 people went to Singapore, and you can see the impact there. 3 people went to the United States. We had 1 healthcare worker who was affected with SARS. 1 person went to Ireland and nothing happened. I can't really explain that, but 2 people went to Canada, and there was 18 healthcare workers affected, 11 close contacts. And that's really, there was a lot of study that came out of the impact on healthcare workers in Canada. Those things are worth looking at and considering. Between November 2002 and July of 2003, there was about 8,100 known cases of the disease worldwide, 775 deaths with a mortality rate of 10%. Fear of infection was very widespread. The public health information hotline in Toronto received over 300,000 calls, including 41,000 in a single day. So this reminds us that the surge to your facility may not just be people walking in, it may be people who are calling you also, and you need to beef up your area where people are calling in to be able to handle those calls from concerned patients and concerned citizens. So numbers of calls handled by staff at that Toronto hotline range from 214 to 1,471 in a single day. So again, got to plan for those psychological consequences, got to understand how that may impact your facility. The other thing that's similar with SARS and Ebola is really the effect on healthcare workers, and really the need to do better of taking care of the mental health needs of our healthcare workers. So that's why we have mental health information on our EMS agency website specifically targeted to healthcare workers. So in Toronto, more than half of the people who were quarantined were healthcare workers. Fear and infection control procedures changed frequently, and that led to some isolation and stigmatization of healthcare workers. We are seeing some of that as a result of the Ebola. One of the things that our public health department has said is that because Ebola is an emergent disease, it's expected that infection control procedures will change. So even letting healthcare workers know that that's an expected part of the Ebola response is something that can be helpful. CDC and others are trying to, as we learn about this emergent disease that has never happened in our country before, more information will be added. The thing to know about the SARS pandemic in Canada, that there was some rates of psychological distress that was very high. People who were quarantined, some of them did develop symptoms of psychological distress, including post-traumatic stress and PTSD, PTSD and depression. 30% of healthcare workers reported job burnout 1 year later. So if we have a situation where your staff is quarantined or they're actually become ill, you really need to think about what your strategy is going to be to address the concern of that staff member, their family, and everybody else who is working in that facility. So the thing to know about mental health needs following a disaster is we have to remember that mental health is the most enduring consequence of a disaster. Long after the damage has been cleaned up, the mental health part really does endure. And so we really need to be far more proactive than I think we are usually in terms of really planning for that. So if you're thinking about the cascading effects of mental health in a disaster, you think about it's like a pebble, dropping a pebble in a pond. So there are people that you know who will obviously be impacted because they were there at the disaster. They had close proximity to the event. And then there will be other people who are, again, directly affected, who may have been ill. Family members. Then people who we consider to be vulnerable population groups who may not have been at the site of the disaster, but may be affected if services or breakdowns, for example, in the case of a hurricane or what have you. But they're already vulnerable, and so they may be disproportionately affected by that disaster emotionally, and we have to plan for that. And here's the staff concern following a disaster. So that's kind of the psychological consequences of a disaster, and hopefully I've made the case for why it is that you do need to include that in your disaster plan. And hopefully I've given you some links to our website and other things that might be helpful for you in meeting that goal of improving your disaster plan. Now we're going to talk about that characteristics of emergencies that really trigger psychological effects. And as I'm going through this, I want you to think about also what's happening with the Ebola, because there's certainly been some triggers of psychological effects for that as well. So when we developed this training, we looked at the triggers of psychological effects, and we based it on, as you can see at the top, a terrorism incident or other public health emergency. We did that because that is where the funding came from. That was the intent of the funding. But you can use this for all types of disasters. So when a disaster occurs in the community, I want you to start to think about the aspects of the disaster that will actually trigger the psychological consequences that you need to plan for. The psychological triggers include restricted movement, limited resources, trauma exposure, limited information, perceived personal or family risk, and emotional, and all of those triggers do cause some short and long-term effects. So we're going to go through each one of these triggers. The first one we're going to talk about is restricted movement. And that has to do anytime a disaster has a limitation on movement or interaction with others, there is going to be a psychological impact for that. Things like isolation, shelter in place, decontamination, quarantine, increased social distancing, evacuation. So, for example, in the Ebola situation, we're having people who are isolated. They actually are ill and they're isolated in the hospital, and there's some psychological concern that people are going to have ongoing for being isolated from family members, isolated from colleagues. Shelter in place refers to the fact that you can't leave your home or place of business following a disaster due to damage or some other reason. Anytime there's isolation, shelter in place, any of these kind of limitation and movement, the psychological consequences and reactions will go up. Decontamination is a very unique type of situation in a disaster, and there are psychological consequences for that. So when I teach this course in LA County, I walk people through the decontamination process so that they can begin to think about that from a psychological consequences point of view. Decontamination is mostly done at hospitals. However, you may have a patient at your clinic who has been through this experience and is coming to you with long-term health concern about how whatever they were decontaminated from will impact them and their family members, but also they'll have some ongoing concern about what that experience was like. Decontamination, if you don't know, you're going about your business, you're at some type of like a game, a sports event, some type of concert. Something happens and you have to be decontaminated. It can happen in the field or it can happen at the hospital. Sometimes it happens at clinics. But you're asked to take off all of your clothes. Somebody who's wearing sort of this thing that looks like a moon suit is washing you down. You go through the decontamination process. You go into a clean area where they hand you some kind of paper gown. You've been separated from your family members. You're most certainly separated from your possessions, your car keys and everything else. And you're in this clean area. I always recommend that hospitals put a mental health person there, an infection control person there, and perhaps a chaplain to be able to deal with those psychological consequences of that experience. You can imagine going through that in terms of modesty issues, language issues, all sorts of issues that go along with decontamination. If you want to kind of see what decontamination looks like, then one of the things I recommend is the old movie Silkwood with Meryl Streep and Cher. Shows that kind of that emotional part of being decontaminated over and over again. Quarantine has to do with people who are exposed but not yet ill. You can see sort of the impact of that in this country with Ebola. You can imagine sort of the emotional impact for people who are concerned that they may become ill, what that may mean for them, and there has to be some kind of mental health response to that. Social distancing has to do with things like closing schools. We saw that during H1N1. That does have an emotional impact. And evacuation has to do with having to evacuate your clinic, your hospital, or your home. So that's restricted movement. Limited resources has to do with the perception or the actuality that the resources for that disaster are not adequate. Supplies are limited, distribution is seen as limited. That you have seen during Ebola, there is some concern about personal protective equipment. Are we using the right ones? Do we have the right things in stock? If we get a patient, are we going to be protected? So again, you can see sort of the psychological concern clearly based on those limited resources. So one of the things that I recommend is that there's an emotional or psychological benefit for your staff to doing all those disaster exercises, showing them what equipment and supplies you have on hand. Right now, you're probably doing drills, going through your Ebola procedures, that sort of thing, maybe doffing and donning PPE. All of that can be very, very helpful to mitigate the psychological concern of your staff. Trauma exposure is something that you should have a system to sort of monitor what your staff has been exposed to following a disaster. That has to do with witnessing or being a survivor of a traumatic event. With clinics, we not only, you may see cases that you wouldn't see on a normal day, injuries that you would not see on a normal day because the hospital has been impacted and people are starting to come to your clinic. So you may have experienced those sort of battlefield conditions in your clinics if there was a very traumatic type of disaster. And also there's cumulative exposure for your healthcare workers in terms of things they see every day, plus in disaster, just seeing those things much more frequently in terms of death and injury. So you need to be able to monitor what your staff has been exposed to. And likely, following a disaster, there may be patients that come to you that were highly exposed to that disaster and may need more than physical follow-up for that event, and they may need some psychological referrals or for trauma counseling. You need to be aware of that. In Los Angeles County, I should also mention, we use Anticipate, Plan, and Deter is our staff resiliency training, but there's also a monitoring tool in there for staff exposure. Limited information is the actual perceived lack of appropriate information about risk, symptoms, and recommended actions. The key in a disaster is to over-communicate with your staff. Certainly with this Ebola situation, you should be communicating very regularly with your staff. You may need to communicate with their family members. So whatever your crisis communication plan is, you should be using that. If you have a mental health person in your staff, in your clinic, you can use that person or persons to help you to formulate the elements of your crisis communication. We all know that information and the way that you communicate information are two different things. One can really help to alleviate people's concern, can be very reassuring, and you can say the same information in the wrong way, and it can be highly impactful for staff and cause people to panic. So there's certainly a psychological way of, there's some wisdom that goes into how you communicate information. But do it proactively. Don't wait and think that people don't give time for people to make things up. Give them credible information as quickly as possible. Perceived personal or family risk is the #1 reason why staff do not report to work following a disaster. So you really have to address, when you're talking about the disaster and you're really communicating with your staff about what's happening, you need to talk about what happened, what your clinic is doing about it, and how you're going to take care of your staff and their families. Those kind of things are very, very important. You have to directly address people's concern that they may become ill or injured, or their family may become ill or injured based on working on that disaster. The other thing is that you may have to have a strategy in a natural disaster I can think of. I'm thinking of Hurricane Katrina now, where people did not come to work unless the facility had a plan in place to shelter their families also. So when you're thinking about what your staff plan is going to be, you may also have to think about what you're going to do for their families in order for your staff to report to work. So one thing I want to talk to you, this is on the EMS agency website, so we're talking about those triggers that I went through. And you can see that here's something that I put on our website for hospitals and clinics that gets at those key triggers of reactions. So for example, I'm again telling people to implement their communication plan, to communicate with staff, especially if there's alarming stories or rumors. Consider the unique needs of information needs of non-medical staff, having something available for the patients who are coming to your clinic who may have questions, for example, about Ebola. Having sort of non-stigmatizing way to address staff concerns, like having an infection control person, walk around as people are working and ask if they have any questions and being available. Having like a drop-in center at your hospital or clinic where people can drop in and ask questions about Ebola, for example. You'd have an infection control person, a mental health person, and perhaps a chaplain, and they can get information there. And again, increase the frequency of training, exercises in Ebola, so the staff feels assured that you're taking every precaution possible. There's a mental health benefit to all of those things. Okay, we're going to move on now, again, a little bit more about the preparedness part and what kind of things you need to have in your disaster plan ahead of time in order to respond to the mental health needs of your staff and your patients following a disaster. So when I talked about the triggers in the previous section, I want you to imagine if you took those triggers of a disaster, so every time a disaster happens, you're going to look at those triggers of psychological concern, because that's part of how you're going to strategize in terms of your response. Here you're kind of looking through your clinic, your facility, and you're kind of determining where those psychological reactions are likely to occur. So usually they are where people enter and exit your facility, where survivors are being treated, where people are congregating, your front desk, your waiting room areas. So that's where the upset people are going to be, your staff areas also. And so you need to, when you're thinking about your mental health response, you're thinking about where's the concern going to be in my facility and how do I address that? What strategies am I going to be using for each area in my facility where these things might occur? So you have to think about, this is more for hospitals. Sometimes in a hospital, fire and police may come with injured staff, and there's a whole strategy for what you do with them. You may be called upon to have a waiting area for families and friends who are waiting for family members who are being treated. And so there's a whole strategy behind how to do that. And again, remember, there's a Family Information Center plan on the EMS agency website. So if you think you want to do more planning about that sort of safe area for families and friends to wait in private, that is on our website. Again, if you're going to have some kind of mental health response where you might be working with people who are upset or concerned, you want to make sure that that occurs away from the treatment areas. When you're planning for your mental health response team, you have to think about, well, if I was to do some response for my patients or for my staff, what would that look like? Who would I need to use to do that? Do I have mental health staff on hand? If our facility had to manage that for 3 days, what would we do? Do we have agreements with other clinics that we can borrow mental health staff? Can we kind of partner with the hospital? Can we partner the local hospital? Can they loan us staff? Can we talk to our mental health department? So you have to think about how that response may go. And certainly one of the things to know is that in hospital incident command, we use hospital incident command here. Our clinics use hospital incident command, but they have modified it for the clinic environment. But one of the things I want you to know is that there are some specific job action sheets for mental health. So if you're not using them, you're not aware of them, you need to be more aware of what those are and assign staff to those positions prior to the disaster and actually use those positions in a disaster exercise. So there is a HICS Behavioral Health Unit Leader. You can look up Hospital Incident Command. It's on our website in California, our state EMS authority website. But there's a Behavioral Health Unit Leader, and that's specifically to plan and oversee the mental health response for the patients. And then there's an Employee Health and Wellbeing Unit Leader, and that person is specifically responsible for the employee health and well-being, including the mental health support of staff. So again, if you have to think about what your response is going to be. What's practical for you it will vary from facility to facility. But just because you don't have mental health staff doesn't mean that you shouldn't be planning for some type of support of your staff and support of your patients. There's got to be some mental health piece in there that you've planned for in your disaster plan. If you want to use mutual aid, you want to use staff from another clinic, you want to set that up ahead of time. And so that's sort of the disaster planning end of it. Now I'm going to talk to you about some tools and resources. And we have one tool in particular I want you to be aware of called the repeat tool, that you can actually take that tool and look at your disaster plan to see if you have the elements in there for managing the psychological consequences of a disaster. So you want to use these things before, during, and after. This shows all of the things that we have on the EMS agency website, from definitions all the way down to that repeat tool that you can actually use as a quality assessment tool to see if you have the disaster planning elements in your disaster plan. And some other things are also on our website. This is LA County specific, so when you do this training, you just have to change this slide in terms of, this describes how hospitals and clinics get more mental health resources. They go through the EMS agency. We are the broker of resources through our department operations centers for hospitals and clinics following a disaster. Now, this is a little bit of an exercise where when I do this training, I walk people through a scenario. This happens to be a radiological dispersion device going off in downtown Los Angeles, and talks about the deaths and the injuries and the patients and the loved ones and staff and hospital and clinic staff that may be contaminated. Staff don't understand the risks and are anxious and hesitant, and they're hesitant to report to work. Some staff don't come to work. There's a lot of people who are contaminated. So if you have this disaster that it would occur in your community, again, you're going to look for the triggers of psychological concern, because that's where you're going to base your response. This is what we talked about in terms of the triggers. So based on that past scenario, and if we were all in the room together, I would be asking you to tell me what triggers of psychological distress or consequences you could see in that prior scenario. So since we're not all together, I'll just have to go through this with you. So staff may be contaminated because they lack protective gear. This is limited resources is the trigger. Patients and their loved ones are exposed to gruesome images as they enter the ER. That's traumatic exposure. Staff don't understand risk of exposure, and they're making them, that makes them hesitant to report to work, and that's limited information. Injured will require some decontamination before hospital admission. That's restricted movement. So again, in the hours and days following the attack, dozens of staff don't come to work, and that's perceived personal or family risk. So again, you're looking at the disaster, you're looking at what the triggers might be, you're looking at what the psychological consequences of that may be, and then you're bringing up your disaster plan and especially what the part of the plan that has to do with those psychological consequences. This is a pandemic influenza scenario. You can use this when you train this course. Since we're in the middle of Ebola, I don't think we need to go through this one. But it's very similar to the SARS and what we're experiencing with Ebola in terms of concern of healthcare workers, concern of the public, and a lot of psychological consequences that really do need to be addressed with appropriate information, with reassuring and calming strategies for staff and patients. So I'm just going to go through this here. So here's some other tools that I want to make you aware of within Los Angeles County. We have something called the Zebra Book in the LA County Department of Public Health, which has all of the terrorism agents in it, and it's in plain English, easy to understand, all of the agents, what they do, the medical countermeasures. So if you're thinking about some type of disaster having to do with chem bio, and you want accurate information to give to your staff, this may be part of your education arsenal, is to use these kinds of resources. We do have a recommended actions tool that you'll find on our website where we talk about various triggers and strategies for each one of those triggers. This is the strategy for decontamination. And again, it really has to do with what to do prior and after the decontamination process that might help address the psychological concern that comes from that. The other thing is this is sort of a triage tool. It's an early triage tool. We now use SciStart. But it's something that I want you to look at and consider. And again, we're trying to go for a strategy that's not the one-size-fits-all strategy. People who have been highly exposed to the disaster, your patients and your staff, need a different mental health follow-up strategy than people who are less exposed. And so that's kind of how you evaluate that. So first step being a medical evaluation, you need to get the medical mission out of the way first before you can work with the psychological concern. If a person was highly exposed to that disaster, they're seriously ill, they're deceased, you need to deal with their family members, that's one type of mental health response that you would probably want to devote a mental health staff to. On the sort of the orange side is this process you go through to see kind of level of exposure and work with the strategy there. So this breaks it down. The first part again, people who were exposed, that's one mental health strategy requiring a follow-up. People who low to immediate probability of exposure, minimal or no treatment, then you're going to do an evaluation based on whether they were actually had a close approximation to that event. They were closely tied to it. There was a traumatic loss. They were closely exposed to that disaster. Those people may need some kind of psychological follow-up. They're probably certainly going to need something a little bit more than psychological first aid, and you need to have a method for how you're going to either provide that or for your facility, or you're going to refer that person for appropriate assistance. Here's again secondary loss assessment, and whether or not they might need some non-urgent psychological assessment, some follow-up. And then people who were not exposed, those people who came to your facility, they thought that they had symptoms, but they weren't actually exposed, they were nowhere near. That group, you can probably do some psychological first aid, talk a little bit about coping with disasters, and a non-mental health staff could provide that So with this, our idea is that having those procedures and processes in place will help your facility to prepare for the psychological consequences of a disaster. You need to have it within your structure. There needs to be a process for responding to those that impact of a disaster. And then appropriate mental health disaster response really depends on having those processes and structure in place ahead of time. So let's talk a little bit about how prepared is your facility. So when you're thinking about your clinic that you're from, it's good to think about how prepared you are for that psychological impact of a disaster. Do you have something in place already? Do you need to do more? So here we would recommend that you use that.
Sandra, 10 minutes.
Okay, that repeat tool to assess the baseline score. So let me kind of go through there. So final thoughts for you. As a result of hearing this presentation today, here are some things that I would want you to do at minimum. Add one or more mental health professionals to your facility disaster planning team. If you have a mental health person, put them on your team so they can work on those psychological consequences. Pre-identify one or more mental health staff or clinical staff for your positions in HICS, the mental health positions in HICS, the employee health one and the behavioral health one. Recruit staff for your disaster mental health planning team or health team, response team, and include a surge of psychological casualties in your annual exercise program. We typically have a scenario for an exercise, a disaster exercise that always includes how many people were injured or killed, but it doesn't always include the psychological casualties. So put that in. Put a surge of psychological casualties that are 4 times the amount of the physical injuries and see if you can practice your disaster plan. This is the repeat tool that's on our website. So I'm going to go ahead and stop. There's my contact information, and if you please feel free to contact me if there's anything more that I can do to help and assist you. And now I think we should go ahead and ask some questions.
Thanks, Sandra, for this great presentation. If you have any questions, please submit your question through the questions box on your control panel, or use the hand raise icon and your line will be unmuted. And we have the first question, Sandra. Do you have these materials in Spanish? Have they been translated in Spanish?
Oh, the training materials?
The training material.
Not been translated to Spanish. Some of the what you call the handouts that you might give staff have been translated into Spanish, and whatever's translated is on the website.
Great. Thank you very much. There is another question. Are you aware or are you familiar with any other similar state systems in place, or a national agency that is doing the same that the LA County Health Department is doing?
In terms of the mental health preparedness piece, there are some other states that have been working on those things. My colleague, Dr. Chip Schreiber, Merritt Schreiber, who's developed SciStart, has worked in some of these other states, Washington, D.C., Seattle, and some other groups that are working with that. SciStart is also used nationally by the American Red Cross. And if you wanted to see it, you could take the psychological first aid course with the Red Cross, and SciStart is in there. But yes, there are other jurisdictions. If you have a specific jurisdiction you want to know about, you can go ahead and ask, either ask me now or write to me, and I can look to see if there's something else happening in that state. But yes, there's other. Texas also has a response to this.
Thank you very much. There is another question. You mentioned when you were talking about Ebola, how these drills and training help healthcare professionals. Uh, do you know if these drills or tabletop exercises reduce the psychological effects during an emergency event?
Um, yes, they do. If you're asking me for specific studies, I can't cite them right at the current moment. There has been some studies on using resiliencies training for staff and the having a better coping with the disaster that I could refer you to, but just despite the research, just logically, if you walk people through and have them rehearse their response and their role to a disaster, they will do better than those that don't really know what's happening, are concerned, don't really know what their place is in that disaster situation, don't really feel that their clinic is prepared because nobody ever told them about what they needed to do. So logically speaking, having that done ahead of time and keeping doing that, especially during this Ebola response, I think it's very, very important.
Okay, thank you very much. There is another question in the queue. What kind of help is planned for disaster workers, specifically government employees, volunteers? The person is referring to people who don't normally work as first responders or in healthcare settings?
Oh, well, in the healthcare setting, our strategy is that in Los Angeles County is that we want to give people resiliency training. So in other words, we want to walk them through the disaster ahead of time, let them know what to expect and how it might impact them, what they might be exposed to that's different than a normal day in a hospital and a clinic. We also use monitoring tools, not for symptoms, but for exposure, so that the employee health and well-being unit leader can look at what everyone in that facility was exposed to and then come up with a strategy for follow-up, which could go anywhere for our information meetings, psychological first aid, crisis intervention, all the way up to engaging the employee assistance program, to referring people for trauma-focused cognitive behavioral therapy or some other type of strategy. But our strategy is to work on the front end, not to wait. We know healthcare workers are going to be impacted by disasters. So let's not wait. Let's do something ahead of the disaster to help people to understand how they might react, help them to develop a coping plan, have systems in place for monitoring. Then do our strategy from there. And let's work beyond a psychological first aid and have a strategy for people who are very, very exposed to that disaster. And they're going to need a different strategy than perhaps the rest of the staff is going to need. But we've got to move away from that one-size-fits-all. So I'm not sure if that's exactly what you were asking me for, but our strategy really is based on staff resiliency training prior to disaster.
Great. Thank you very much. Now, there is one person asking one more time for your contact information. And
oh, here we go. There it is. I hope everyone can see that. And please feel free. I'm just hoping that there was one thing I said or some resource that I offered today that will be helpful, that you can immediately adapt and use. But please feel free to contact me if I can help you any way. I'd like to do that. You're so important to our healthcare system, and we want to keep your staff functioning well. Your medical mission depends on people keeping their stress level as low as possible. And I will do whatever I can to help.
thank you very much. There is one more question. Should drills or tabletop exercise involve or include patients? That's question that we have just received?
It depends. I mean, usually there's different levels of exercises. One is like a tabletop that you would do with your staff to look at your disaster plan and see if you have everything in place. Then there's functional and full-scale exercises where you may do an actual response. We typically use somebody who's playing a patient, or the children of our staff. But you could involve your patients if you thought that would be helpful, and if you wanted to. You have to think about what the goal of that would be. Do you want them to know more about your disaster plan? Do you want them to show them that you're prepared? So you have to think about that goal. I wouldn't say don't do it. I would just say, be aware of what you're trying to get out of it in terms of education for them, and how it might benefit your staff to actually work with live patients for a disaster drill.
Great. Thank you very much, Sandra. And I don't see more questions in the queue. Thank you, Sandra, one more time for keeping us abreast on these emergency preparedness issues. And to all of our attendees, please complete the post survey. Your feedback helps us improve our webinars. Also visit our website, www.nchph.org, where you will find webinars, monograph, fact sheets, training manuals, newsletters, information about our annual symposium, and information on one-on-one training. You can also join our mailing list and receive HRSA updates, Medicare updates, funding opportunities, information about senior programs, resources and services, and information about our webinars. You can also follow us on Twitter, and you can also subscribe to our YouTube channel. Once again, thank you very much for attending this webinar, and Sandra, one more time, thank you very much for all your time.
Yeah, it's my pleasure, and I'd be happy to do it again if there's something else you want me to present on.
Thank you very much, and have a great afternoon.
You too.